Dr. Philip Ajuk, can you confirm, please?
I'm on call, Sec. Thank you.
And I'm going to request that you flash the slides on. Why I'm requesting that from your window, it's because you have been leading this exercise with our consultant, Dr. Pio Pasca, and I know no one compares to you so far in our region. A very strong team leader. So through you, Mr. Chairman, with your permission, I'm going to request that Dr. Duke Philip speaks, but while he's speaking, I will actually be behind that voice. He's representing me because he has been driving this, and I don't want to pick the baton at any hour when at least we shall be applauding the team. Yet he's really has been a good team lead. So, Mr. Chairman, allow me introduce Dr. Duke Philip, our head of public health, consultant public health, to take us through the Acholi Regional Progress Report on Integrated Health Service Delivery. I thank you, Mr. Chairman. Dr. Duke, kindly shoot.
Philip, you can start. You have less than 30 minutes.
Thank you, Sec, for this opportunity to present on behalf of Acholi Sub-Region. Chair on call, we have also the head of DHOs, Dr. Ochula, and all the DHOs that are logged in. We also have the different focal persons on integration in the region. We also have the regional referral team, that the foot soldiers that are working within the different wards that are offering integrated care to the patients. And I'm also presenting on their behalf. I'm Dr. Philip, like the senior executive consultant has pointed out, and head of public health department. On call, we also have Dr. Pascal Pio, the consultant, public health, who will also be talking at some point in regards to the questions that will be coming up. I'm presenting the regional progress on integration, and I'll be talking about the journey, the background, the progress we've made, the achievements, the drivers of improved implementation. We are going to spotlight a few facilities that the Ministry of Health has recently visited, and we shall be giving feedback on the support supervision that was held on integration, the challenges that we've encountered through the process, opportunities for improvement, and of course, the next steps. Acholi Sub-Region has 10 administrative subunits. That includes the 9 districts, the 8 districts, 1 city, Gulu City, and a municipality. We are serving a population of over 2 million, and with 351 facilities as per DHIS2. And we have been, as a regional referral, at the center of pushing the integration agenda. And as we well know, integration is really a comprehensive approach to patient care, and of course, including the patient-centered approach. And this has been a shift from the vertical disease-based approach that we've been having. And this shift, like the DG has clearly stated out, it's meant to consolidate services, optimize resources, and time. And as a regional referral, we piloted this from January, following actually a directive from the ministry in a phased manner. In the first phase, we had integration of stable persons living with HIV from the ART clinic and joining the general OPD. We, at that point, when we had received the directive from ministry, we had patients who were stable on and had stable viral loads initially transferred to care within the OPD. And in phase 2, we integrated all these patients into the general OPD. These were in the space of about 1 month as we picked lessons from the process. And in the third phase, we integrated all the children and adolescents with the HIV into the adolescent clinic. So we are having a mixed model OPD, 2 OPDs, one for the adolescents and for the adults. Children and adolescents, then for the adults. Following a circular by the PS in 2025, in February, we adopted a roadmap on full implementation of integration, not only within the facility, but also within the region. And following the emerging best practices that was harvested from Gulu Regional Referral that piloted the integration agenda in the region, we reached out to the different spokes within the region. We're talking about the district hospitals and the health center force that were in charge, the health center force that were acting as the hospitals. And we, through support supervision in March, we were able to concretize and ensure that all these facilities, all the different spokes are up and running as per the notice from the PS. We established a virtual learning platform to harvest these best practices and also weekly coordinate the integration agenda every Tuesday. We also encourage the different spokes to reach out to us at Gulu Regional Referral and benchmark. And notably in April 2025, Kitgum General Hospital reached out to us through the MS, and they were able to visit and benchmark at our general OPD. And by and large, of course, they had to start off following the benchmarking. After that, we had the regional trainings kick off. And this started from the national TOT. And we had the senior executive consultant and the regional referral team trained through support from CHAI. And later we had these trainings were cascaded down to the regional hospitals and the regional teams, and we had the DHOs trained. And later, the regional teams were able to train the district teams. And of course, we are at the level where we have most of our facilities that have already been trained. Then, as a region, this is just a pictorial of the initial support supervision that we had following the directive from the PS. This is the hospital director actually offering support to one of the districts, and this is the health center 4 in Amor, and this was the HIV clinic then. And we were pushing the agenda of integration and ensuring that all the spokes kick off. And of course, this is our concept that was developed at that time. And we ensured that in that quarter, we were able to reach out to all the districts as a regional referral to support them on the integration agenda. There were key positive observations that we saw from that support supervision in March. And we had really a leadership that was ready to take on the new approach to service delivery that was initiated by the ministry. We had district planning meetings with the DHOs to discuss the integration of vertical programs into the routine care. And thirdly, we ensure that there is continuity of health care service delivery. You may as well note that following the communication, partners pulled out, and some of the services that were being supported by partners were affected. However, as a region, we ensured that our patients continued to receive care at every point. These were some of the key actions that were developed from that support supervision. We had district work plans that were not aligned to integration service delivery then. However, we resolved that there should be DHT meetings to discuss plans for implementation of integration, and also schedule weekly regional virtual meetings. For routine client satisfaction feedback, and we resolve that we need to assign a responsible person to oversee the progress on integration. This has already been done. We have all our districts have focal persons as well as the facilities for the routine client satisfaction feedback. From the pictorial, you noted that the walls were littered. And of course, we encourage them to use the notice board in order to promote the 5S QI model. We ensured that there should be continuous support supervision and mentorships to the different districts on a quarterly basis. So these were some of the actions and we have since then, through the guidance of the senior executive consultant, consistently had support supervision to the districts, including mentorships, where the consultants go and spend at least 5 days mentoring the different spokes on integration. This was in one of the facilities where we had abandoned vehicles, and we said they should be removed, and it's a work in progress. Integrated delivery of services, the coverage as a region, we have close to all the health center 3s and above that are implementing integrated service delivery and performing above 90%, save for Kitgum, where we are having a few facilities at 86%. Most of our health facilities are implementing the mixed OPD model. And you have taken root of the chronic care model, and notably, Chair, are you hearing me well?
We are hearing you well, though it is breaking, but you are hearing you well. Go ahead.
Okay, thank you. It's showing my internet, it's somehow unstable. You have seen the percentage, the column with percentage of health center 3s and above that have completed site level training. Gulu district is the outlier with 58% in red, and this is because as a region, we reached out to the different partners to support the different districts on implementing facility integration. trainings, and particularly for Gulu district, the partner had a few challenges and was not able to, the district wasn't able to complete the trainings. However, it is something that we're discussing with we're discussing with the regional partner complete. Yes, key to note from this slide is that 82% of our health center 4s and above are implementing the chronic care model, while 96% of the health center 3s are on the mixed model. When you look at Gulu City, we have 4 facilities, and 3 of them are implementing the chronic care model, save for the regional referral, which is accounting, of course, for the 15%. We have had achievements as a region following the implementation of integration. One, we have been able to complete all the trainings with support from the partners, CHAI, JCRC, URC, UHA, AVC, and Gulu Regional Referral Hospital, also putting in resources to ensure that there is training right up to the facility level. So as we talk right now, right up to the health center 3s, we have most of our facilities already trained. And we were able to garner support from the different partners to ensure that these trainings are done. We were able to form the Regional Integration Care Committee, which of course I'm a part, chaired by the Senior Executive Consultant and co-chaired by the consultant physician, Dr. Pascal. We were able to assign district integration focal persons to ensure that there is a coordination of the integration agenda in the districts on behalf of the DHOs with the regional referral. These are able to actually report on a monthly basis to the regional referral and give updates on a weekly basis in our different meetings. We have had hands-on health facility-based mentorships and support supervision on a quarterly basis. We have had at least 3 targeted visits since March, led by the senior executive consultant at the regional referral. When we talk about mentorships, we're talking about mentors being on ground and really having hands-on experience with the different integration teams at the sites, while the support supervision is the continuous support supervision that is given to the spokes on the region by the regional referral. We've continuously had the weekly regional virtual learning and coordination meetings, which is really an accountability platform for integration within the region. We have had good partner coordination. We were able to mobilize resources as a regional referral to ensure that the trainings are conducted, and also the quarterly performance reviews are done, including the recently concluded joint review mission, where the integration agenda was a key topic of discussion in the meeting. The drivers for improving integration in the region has been, much of them has been centered around the leadership, the good leadership. I remember when the circular was passed, the senior executive consultant called the consultant, called the pediatrician, called the obstetrician and other top managers to pick their brains on this circular, the agenda of integration. And we reached out also to all the DHOs within the region, and this provided critical leadership to pushing the integration agenda. Trainings of the DHOs, of the leadership, was also key for improving leadership. We had to involve all our DHOs and ADHOs in the integration trainings at regional level. And this has been key in cascading this agenda right to the districts and the facilities. We have been able to build the human resource capacity through trainings and also through peer learning within the chronic care clinics. Client education and sensitization has been key. A few of the clients were doubting on these steps that had been on this new agenda that had been brought up, especially given the fact that they were used to the HIV clinics. However, through health education, we were able to
Dr. Philip, we are losing you.
Philip, have we lost you? Can somebody find where he has gotten lost and bring him back? Our sec, can you pick up from there as we wait from him?
Dr. Philip, it seems we have lost him. Dr. Michael, are you with us? Dr. Michael, are you with us?
Michael is also out of stock.
I think Michael Abbott is on call.
Michael Abbott?
Yes.
Yes, but he's not talking, I think.
Michael, try to unmute yourself. You should be able to speak now.
Thank you, Sec. Sorry, apologies. I was unable to unmute. Admin, please allow me share, enable me to share from this slide.
Yes, you share and just continue from that good practices slide.
Okay, thank you. Colleagues, apologies for that interruption. Yeah, so speaking to this slide, Philip was concluding on it. So this is really about the drivers that we've seen give us some mileage. And of course, the last one here is a feedback from the clients. This has enabled the team to reorganize, but also to sustain what the clients appreciate from the changes that were being implemented. This slide speaks to our current regional performance overall, and I will speak to the spider diagram over here, and we see that the different domains currently, I think we're largely doing quite well. And in terms of the quarterly regional partner meetings, these are happening on a quarterly basis. The district integration meetings, these are also happening. We have, of course, Philip has already hinted that we have a regional care committee, which is functional and up and running. we will continue to be meeting on a monthly basis, among others. So allow me to speak to the next slide, which is showing performance for some selected districts on integration. Again, colleagues, to notice that this is picked from the most recent support supervision that we conducted along with the Ministry of Health. So I will focus again to the spider diagram here, and the key to note, I will speak to a few areas that we've not yet met our target, but we are continuing to work along with the teams. One of them is the annual work plans for integration. This is an area that is still gray. Of course, while we note that the current work plans that are being implemented at the different districts have a component of integration, but not all the districts, only 25% so far have what we call an integrated work plan at the district level. Documentation of best practices and sharing of the learnings is another area. So far, we've had only about 25% of the district share within the regional platform, their best practices. But of course, we put up a schedule beginning this month that we are going to be having all the different districts share their learnings on our regional platform. That happens every Tuesday. We also have within the area of sharing evidence and addressing challenges, it's still a gray area that some of the facilities are not yet able to address the gaps that they have. But with the continued support from the DHT, we'll have these concerns addressed. And this slide speaks to a performance summary for just some selected 8 facilities. And here again, I will focus on the spider diagram here. We see that quality improvement is still an area which is still gray at about 80%. Of course, this is understandable because of the changes that are happening. A number of interventions are affecting the processes. And this is an area where we're going to pay attention in the coming months, as well as service delivery. Then this speaks to site-specific performance, and we pulled out Gulu Regional Referral Hospital, of course, as a center of excellence in the region. And we see that leadership and governance is very important, and we're doing very well thanks to the senior executive consultant for always being at the forefront to ensure that leadership to this common cause is provided. We see a bit of challenges in the laboratory systems and diagnostics, as well as, of course, service delivery here is because of the continued changes that we have been implementing. So this has affected the client flows, and we get feedback from clients, among other things. And this is still work in progress. We'll continue to address that. Community systems is also an area that we are picking up, and we are just at 86% as a regional referral hospital. And this next slide, we also pulled out one of the private not-for-profit facilities in Chitugum. This is St. Joseph Hospital in Chitugum. And this is how they are performing so far in the different domains. Leadership and governance, quite very good. Again, just like we've seen from the overall performance, quality improvement and service delivery are the domains that we are going to be paying attention to, including, of course, community systems. The others are quite okay. Of course, implementing this has come with a couple of challenges. And one of those key challenges that we've been able to observe is that the EMR, the electronic medical records, and EAFIA are not communicating. We're aware that EMR hosts a lot of data, especially for persons living with HIV. So we feel that this needs to be fast-tracked if we can be able to merge these two systems this will save us a lot of hurdle that is currently happening. At the moment, for facilities that are having eAFIA, what we've been able to do is to install both systems on the same computers so that the clinicians are able to work along with the two. The other challenge is data management, and this is at lower health facilities. Some facilities lack integration tools, and they're unable to document some of the processes. Of course, the mitigation measure here, we've supported and asked teams to use the multiple tools that they're using, but this is quite a lot of work, documenting maybe on 2 or 3 tools when you're just seeing one client. So if these tools can be managed so that we can have one integrated tool that can save us a great deal. We also have a little bit of complacency among some district, but also health facility leaders in driving the integration agenda. And we currently are bridging this by providing room for such leaders to share updates in our weekly learning meeting. So this is meant to encourage them to pick up and realize that they have a role to play. And then, of course, low coverage of client feedback and the use of these client feedback results. This is another area that we are currently grouping on, but we are supporting the different health facilities to mitigate this through identifying the practices that are working. And in the region, one of the things we realize is that not many of our clients have smartphones, but also sometimes internet interruption. So we're adopting the use of hard copies for the clients to give their feedback, and then later this information is transcribed into the database. But if at national level, we can be able to adopt like a user-friendly feedback submission process, where, for example, if a client does not have data on their phone, they can still be able to scan this code and the questions upload. Probably the client fills them, and later when there's data, these questions or the responses are uploaded into the dashboard. That can also be useful. So currently, the practice is using hard copy to support clients provide this feedback, and then later someone who has data on their phone is asked to transcribe this information onto the national dashboard. Some of the opportunities we have as a region, of course, this has already been spoken to, the monthly Regional Integration Care Committee meetings. This is going to support us a lot to drive this agenda forward, identifying the gaps, but also providing strategic direction for the region. And of course, working through the hub and spoke model to expand and sustain the gains that we have already made. This is one of the other opportunities we have, and our spokes already at the districts are picking up, and they will take on to provide support to the lower health facilities within their respective administrative units. We are thinking of expanding the pharmacy model to support the clients with NCDs, of course, borrowing from the HIV programming. This is what we think will also help decongest the health facilities. At the moment, most of the hospitals have many clients with hypertension or diabetes, for example, who keep tracking every month or even bi-weekly to the health facilities. So we want to align these clients to the pharmacy model and other community models so that they can also be picking their refills from the community. This slide is a pictorial speaking to some of the events that happened. The first picture on top here is a group photo. This was during the regional TOT on integration. And we have all our DHOs in that picture, of course, with our senior executive consultant. And some of these pictures are the processes during the trainings. The bottom left corner here, this is the Chitugumu district and the cow giving opening remarks during the training. Colleagues, lastly is what we plan to do as a region going forward. One, of course, we will continue to have our monthly regional integration care committee meetings, and we will also implement a regional integration QI collaborative. So this is a work in progress. We have already identified some health facilities that we want to pilot this QI collaborative. Like we saw in the earlier slides, one of the domains where we're still having challenges is on the QI, and this is going to be a continuous process. So we'll implement a regional QI collaborative to be able to try and identify and address some of those challenges, but also implement quick learning cycles that will enable us harvest best practices that will share across the region and maybe for the country at large to benefit. We will continue to have our weekly virtual learning meetings. This helps us to coordinate the teams, but also to share a lot that is happening within the different facilities and the districts. Of course, the quarterly mentorship and support supervision through the hub and spoke model will continue. But at the district level, we will support the districts to lead mentorship to the lower health facilities. And we hope this should be happening on a quarterly basis as it has always been, but we'll try to be more intentional. The regional quarterly performance review meetings will continue. We started to integrate this way back, I think 3 quarters ago. So we no longer have standalone performance review meetings, but rather integrated. We will intentionally work with the partner that supported the site level trainings in Gulu to complete the remaining 3 facilities, just about 3 health facilities. And this we think should be able to handle in this month that has just started. And most importantly, of course, we will track and document learnings from implementation of these different processes on the integration journey. We want to acknowledge the support from ministry and all our partners that have been with us throughout this journey, and we continue to work together to achieve better patients' outcomes. Thank you.
Thank you very much. The multiple presenters with your sake behind the scene. We are very, very grateful for this clear and well-articulated learning and adoption of, integrated healthcare services in your region. Colleagues, I know there have been so many questions posted out there, and we want to take the few remaining minutes to take a deep dive into those questions. And I know some of the questions are still coming, but to note is that one coming from Julius Biekwaso is talking about his observation around chronic care, that chronic care in most health facilities by clinical officers and nurses. He's thinking that we should engage more of the medical officers. That is his observation. If there's anything which you observe differently, please let us know. Fatia Kienga is again saying many of the interventions are targeting health facilities, and is asking to what extent have you involved communities, health unit management committee, and committees like district adolescent health committees. Joyce Zaliwango is saying, is the hospital thinking about assessing experiences of patients and their families in regards to this kind of changes, the change you are talking about in integration? While Katende Ivan is saying, is there a standard tool that can be used to objectively and in the standard way provide correct assessment of this kind of integration you're talking about? More questions are coming in, and I want us to start by answering those very few ones before we pick on the many more. I ask that the SEC plus your team keep your eyes into the chat and pick all those other questions which are coming, which have not yet stated here, so that we keep answering them as they come in the interest of time. Let me ask whoever is on the team from the regional referral hospital who made a presentation is able to start answering or responding to these queries and comments. Thank you. Over to you, the Gulu Regional Referral Hospital team.
Okay, thank you very much, Mr. Chairman, and thank you very much, Dr. Michael and Philip, for those presentations, those slides, which are provoking many people thinking. These slides were actually prepared by all of us in Acholi sub-region. The DHOs were consulted up to a number of other partners that have been part of this. So it's indeed a presentation prepared and presented by the Acholi team. I want to believe that my colleague, Dr. Pasca, is still online. Dr. Pasca Pia is our consultant physician, and she is the regional focal person. I'm the overall team lead, but she's the regional focal person. We also have a hospital focal person. So, Dr. Pasca? Dr. Pasca?
Thank you very much, Sek. Thank you, Chair, and thank you everyone for attending this webinar in large numbers. I'll give my insight. Our team has made a presentation of what the picture of integration of health services is in the region. Amidst the challenges, the achievements, and the best practices that we have, we still have room for improvement. And we also get best practices from the other region as well. I want to speak to the question that was raised about the clinical officers, the nurses are the ones battling with these patients in terms of integration. In the morning, I discussed with Philip that this integration concept is very good. It has a number of benefits to our clients. However, it would fit very well if the new structure of staff implemented. This will the clinical officers and the nurses only attending to patients, especially in the lower health facilities. In some of the region, you'd find that getting a medical officer would be a very big challenge to the client. So if alongside the integration, the new structure should be on board as well. This is what I want to submit to the issue of COs and the nurses. Indeed, we have also observed that and we are concerned. And we have also encouraged that the patients or the client should be referred at different levels. Even if we are talking about integration, there would be one point that you need to still refer to the higher level. From Health Center 3, Health Center 4, District Hospital, up to the Regional Referral Hospital. As a Regional Referral Hospital, you also realize that we don't other specialized services. We can still refer to the National Referral Hospital amidst this integration. As we know, we should focus on patients, not disease. However, at the moment in the country, we don't have all that technical expertise to integrate all the care that we really need to give patients. There are particular issues that may need particular specialists. Chair, I would like to stop at this. Maybe I would like the head public health department, if he could respond to the issues of community and the involvement of the other district health committee into the issue of integration. However, during our training of the district teams and the health facilities staff, we have engaged and we have staff with the community members. Thank you. Over.
Okay, Dr. Philip. go straight
Yes.
ahead and speak to what Dr. Pascal has mentioned, but also speak to the issue about the tools which are standardized, because we have a standard tool, but I know you can use more. There is someone who has hinted about, do we have a tool for assessment? Also talk about how the CDDPs, how we are integrating the NCD's clients who need the medications, recurrent refills, our community involvement in that regard. I think it was something to that. I hope it is clear to you. You can go ahead.
Yes, thank you so much, Sek. Just a rejoinder to what Dr. Pascal said. We, as a regional referral, we have 3 medical officers that have been assigned to the outpatients department. So that has actually been taken note to engage the medical officers as well. Though, like Dr. Pascal said, we need to implement the new structure to work effectively. 2, there was a question to what extent we involve the communities. You are aware that prior to when we had the vertical HIV programming, we had the CDDPs, where stable clients in the communities were receiving care from the different points within their communities. And we had a challenge following the Trump stop work order. However, the regional referral through the senior executive consultant was able to actually allocate funds for community outreaches to these CDDPs. And now we are saying that we are going to be doing it in an integrated manner, where we go and see these patients, and the patients are seen in a more comprehensive manner. And prior to that, we had 48 of them. Now we managed to integrate some of the CDDPs that are closed, and we continue to do the outreaches. I want to thank the senior executive consultant, because we are actually increasing our scope based on our budget. We are increasing our scope to be able to reach more people within the communities through this same model. And as already preempted in the presentation, we also have a pharmacy model where we are having patients that are stable go directly and pick their medications within the private pharmacies, of course, with support from the regional referral. This is still ongoing, and it's one of our community initiatives. Someone talked about a standard tool to assess integration. Yes, we have a standard tool. And partly, when you looked at our presentation, the different domains, the different domains that were presented during support supervision, that's actually picked from the tool that we use for assessing integration. It is a national tool and it's available. Assessing patients and their families, it's a work in progress. However, we at the regional referral, we are continually assessing patients through the counselors that are available and the social work department. However, within the community, it is something that we're just starting to do because it was a challenge at the beginning following the withdrawal, but now the roadmap is clear, and we are going to be making these outreaches and assess patients and their families through our social work department. Thank you.
Okay,
thank
Sek, we are running short of time, but I think with your team, you have picked some very salient questions and comments on the chat. I would like you to respond to those ones you think are really deserving of your answers and response, so that we see how to conclude. We are running short of time. Over to you with your team.
Okay, thank you very much, Mr. Chairman. and to my colleagues for the responses, and the colleagues for the very many questions that I'm seeing in the chat. I believe we are going to pick on most of these questions, because some of them actually suggestions on some things we need to do, which we are really picking on, and we are going to work with them. Mr. Chairman, first of all, what needs to approach to appreciate is that as we change towards the holistic approach to managing our clients, we are changing a system which has grown over 3 to 4 decades. And indeed, what is expected is that often you get those pockets of resistance, either on the client side or the health workers side, and name it. So that is what we have first appreciated, that it isn't going to be an overnight change and everything is perfect. It has to be work in progress, as Dr. Juk mentioned, and it will really continue being work in progress because the system that we are changing was so robust, and we now need to make it even better through this holistic aim that we have. Now, by and large, my colleagues I know picked on many of the concerns and addressed them. Some of them may not have immediate answers, I believe, but as we go by, I know this interaction is just one of them. We are going to pick on those which don't have answers. They will be like questions for us. Why don't we do that? However, what is coming out markedly and also came out in the presentation is about the electronic medical record system. What we are using, the eAFIA mostly, some of us, it seems it isn't yet good enough to enable us have the integration up to that level of being able to capture our information in a holistic manner. I think we haven't yet reached there, but we know that we are in touch, of course, with your offices, Mr. Chair, at the Ministry of Health, and we know that the system is continually being improved, and we are going to reach there. For instance, someone pulled it out that it doesn't have all the MNH tools that we need, and indeed it may be true, but I know that work is going on, and we have to fight in there. But as we were presenting, you noted that, for instance, the Uganda EMR system, the one we were using for HIV clients, was so robust that we just can't throw it away. And what the presenter mentioned is that now we have, our clinicians have been trained, at least at the regional referral hospital, to use both systems now concurrently, as the developers are working on a way of integrating all the parameters we need from the Uganda EMR into the eAFIA. We decided that it's the only way to go. We won't throw it away completely, so we are using both of them, keep on somehow to serve our clients better. Now, Mr. Chair, something came out about the infrastructure issues. Indeed, we have problems with space, and they were there even before integration, yes. However, I believe my colleague mentioned it very quickly. We changed how the client flows are. And one of the things that we had to first change, previously we had days, specific days for particular conditions. You say now Thursday, it's for hypertension. Then we have a day for sickle cell. We have a day for diabetes. That was the first thing which we changed, thinking that if we spread the clients through the week, these congestions would stop because of the limited space, yet we are pulling thousands of people on one day. And when we did that, we are now offering all services on all the days. Progressively, of course, people also, the clients are still changing. Some of them are stuck with their days. But we do know that as we work along, they are going to get used that actually it's every day, and we believe it will partly reduce on the congestion which is there. Mr. Chairman, as I get to the end of it, the last one I will speak about is about the management of appointments, which was also in. This was strongly managed into the Uganda EMR system. Now, we got a lot of confusion when we were just starting and we were putting away when the Uganda EMR was off, and there was a very big challenge in managing appointments. Much as it isn't yet 100% perfect, as now we are using both systems. First of all, especially for the HIV clients, we're using both systems. Those appointments now we are getting back on track. The real problem or the real the real challenge, the remaining challenge now is the managing of appointments for these other NCDs and other conditions on the e-Afya system. The system is not yet very perfect for managing appointments, and we are using, in combination, trying to use the e-Afya system, yes, but also the appointment registers are not yet thrown out. So that one is still a little bit a thorn in our flesh, but there is work in progress to make sure that we improve it. So, Mr. Chairman, I know in the interest of time, by and large, we are 9:15, and I know we agreed to be here up to 9 to do other business. Allow me to thank my team, the district health officers, because they are leading a lot in those districts. And as we are scaling up the integration into the community approaches, of course, we are going still to rely a lot on them, because they have a lot of community interventions on their own, which they can do without us necessarily even being there. So I submit, Mr. Chair, and thank you for giving us the opportunity to share where the Acholi sub-region is in integration. At least the big note from my side is that we are above 93% as the scope of integration, and we know that in a couple of months, most of the facilities above Health Center 3, at Health Center 3 and above, they will be on track as we continue to review our performance with the teams. I submit.
Thank you very much. Thank you, colleagues. Whoever is still online with us, please unmute and clap for the big presentation, responses, and whatever the team has presented to us. Colleagues, you can see that on my attendance list as we were making the presentation, we were close to 750, 760 on high. And that was a very wonderful attendance. And we encourage you that whenever a webinar like this is posted to you, please don't hesitate to join, because as you know, integration is a process, and there are many learnings we are going to take from there. And I'm sure those of you who are from other regions like Western Uganda, like Eastern Uganda, at least you have picked one or two issues, which is a learning from this presentation. And you have seen that Gulu region is now standing at approximately 93% of integration level. And I think we give thanks to the leadership, but also to the partners who have supported in making sure that the process of integration moves on as planned. We give gratitude to CHAI, JCRC, URC, ABC, and many others whom I may not have seen on the screen here. We are very thankful as a ministry, as government, to make this process work. But also, you know that in this process of integration, we are looking at integrating the programs, we are looking at integrating the human resource, we are looking at integrating the infrastructure, and integrating the funds with the ultimate goal of having one plan, one budget, one M&E. It's up to that level, that point, that we shall begin to say we have fully and successfully integrated. Thank you for those ones who have tried to post questions, comments, and whatever appreciation you have put on the screen, but also continue to send through your comments, if they are still there, your questions, and whatever you want to do to encourage this team to do better. We want to say thank you for now. And I know my DG is not online. If he's not online, allow me now take the singular honor on his behalf and on behalf of... Is somebody talking? Okay, allow me take this singular honor and on behalf of everybody, say thank you and goodbye. See you again.
Thank you.
Thank you, Mr. Chairman.
Thank you. Thank you. Bye-bye.
Thank you, Chair.
Thank you, Team Acholi.
Bye.
Thank you.
Thank you. Thank you and
Thank you.
bye-bye. Thank you.
Thank you.
Bye. Thank you for presenting.
Thank you and
Thank you.
bye-bye. Thank you and bye.